So today's topic is evaluation of male infertility and its history-taking examination, what all investigations should be done and what should be the management. The causes of infertility, the male factor accounts for 40% of the infertility, around which the 20 to 30% is solely the male partner is responsible, and it is another contributory factor in 30 to 40% of the cases of infertility, and the rest 40% is due to female factor, and unexplained is around 10%, and the combined factor is also around 10 to 20%. The causes of male infertility can be any obstruction, any testicular malformation, like disorders of spermatogenesis can be due to obstruction, torsion, malignancies, infections, or there can be obstruction at the level of vas deferens, seminal vesicles, prostate glands, or ejaculatory ducts, which may lead to abnormal semen parameters, or there can be defect at the penile level due to erectile dysfunctions, ejaculatory dysfunctions. These can cause male infertility. So disorders of spermatogenesis accounts for the majority of the cause of infertility, which is around 50%. The sperm motility is responsible for another 15%, and obstruction of vas, which may lead to azoospermia, accounts for the 30% of the cases. So coming to the recent WHO criteria for semen analysis, this is the recent 6th edition which has been released in 2020. The earlier edition, which was released in 2010, has the semen parameters as the normal cutoff was 1.5 ml volume, 15 million per ml as a concentration, 40% total motility, 32% progressive motility, viability 58%, and normal morphology as 4%. So this has been slightly modified in the 2020 analysis, which has made volume cutoff 1.4 ml, concentration cutoff to 16 million per ml, motility cutoff to 42%, and progressive motility to 30%, viability to 54%, and morphology has been remained same, that is 4%. So these are the slight modifications. The 6th edition has encompassed a larger population, and it has included Asian population as well. So there are minute variations, and this is the recent cutoff for a normal semen analysis. So variability in semen parameters is universal. There can be day-to-day variation. That means more than 50% variation can be there in two analysis, or two semen reports at two different times can also lead to variability. So two evaluations are recommended to establish a profile of seminal parameters, and the period of abstinence count increases with days of abstinence, but quality declines with more than 7 days of abstinence. So generally 2 to 7 days of abstinence is recommended by the recent semen analysis guidelines, WHO guidelines. So below 2, there will be decreased counts, and above 7, the quality decreases. So count will decrease, motility will decrease after 7 days. So 2 to 7 days abstinence should be there. The semen analysis is a guide to fertility, but it is not an absolute proof of fertility of an individual. So if the semen analysis is poor, it does not mean the couple cannot get pregnant. They can get pregnant because only one sperm is required to fertilize an egg, and they have millions of sperms. So semen analysis can only guide that they may have delayed fertility or decreased fertility, but it is not an absolute proof of sterility of an individual. Pregnancy is the only irrefutable proof of the sperm's capability to fertilize. So routine semen analysis provides useful information concerning the sperm production by the testes, sperm motility, viability, the patency of the genital tract, the secretions of the accessory glands, as well as the condition of penile ejaculation and the emission. So these are useful information is provided by the semen analysis. But it is, as we have already spoken, not a test of fertility, and it provides no insights into the functional potential of a spermatozoa to fertilize an ovum or to undergo subsequent maturation process that are required to achieve fertilization. So now coming to what is the oligoacinoteratozoospermia. So it is a diagnosis just like a fever, and in these abnormalities, that is oligoacinoteratozoospermia, there will be abnormal sperm parameters. All parameters will be abnormal in around 43%. Motility only will be abnormal in 39%. There will be oligospermia in only around 10%, and the morphology will be abnormal in around 8% of the population. So coming to the criteria of oats on semen analysis. So when this oligospermia called? So oligospermia is called when the sperm count is less than 15 million per ml according to 2010, and according to 2020 when the sperm count will be less than 16 million per ml, it will be a oligospermia sample. The severe oligospermia is called when the sample has less than 5 million count, and cryptozoospermia is called when there are less than 1 million count or a few motile or immotile sperms are present. Actinozoospermia is called when their motility is less than 40% total motility, and severe actino is called when the total motility is less than 10%. Terato is called when there is less than 4% morphology. It is severe, and when there is less than 14% morphology, it is known as a terato.